All right, it's 12:30, so I guess we'll get started now. More people will log on. So welcome everyone to the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So thank you everyone for muting your microphone once the presentation begins, being attentive to the presenter and engaged in the session, and also completing and submitting a session eval form. And I'll put that link in the Zoom chat for everyone. All right, next slide, please. So here is the activity code for today. So I'll leave this up here for a bit so you can all get your CME credit. All right, next slide, please. And then this is just information how to get the CME credit via text. I'll leave this up here for a bit as well. All right, next slide, please. And then this is just info regarding CME transcripts. All right, next slide, please. And then this is just information regarding the AAFP credit system. All right, next slide, please. And then this is just information regarding the core competencies. Next slide, please. All right, and Dr. Hernandez has no financial relationships with ineligible companies to disclose. Next slide, please. All right, Dr. Hernandez.
Thank you for the introduction. So hello everyone, once again, my name is Wuen Hernandez. I'm currently one of the PGY2 Ambulatory Care Pharmacy Practice residents at University Health, currently under the leadership of Dr. Davidson. And today I'll be talking about to block or not to block Renin-Angiotensin-Aldosterone system blockade, advanced chronic CKD. At this time, I'd like to orient you to some abbreviations that I'll be using throughout this presentation. And next, I would like to review a few of the learning objectives I've listed to be used as our game plan and to help us move throughout the presentation. First, we'll review the etiology and complications of CKD, discuss the physiological role of RAAS blockade in chronic CKD, evaluate primary literature on efficacy and safety of ACE inhibitors and ARBs in advanced CKD, and formulate evidence-based recommendation regarding sustained or interrupted RAAS blockade in advanced CKD. But first, I would like to orient you to a patient case. And once again, this is in relations to the NBA finals. So Granny, 72-year-old female who presents to her PCP for a sports physical and preparations for the big game against the Goon Squad. Her past medical history includes type 2 diabetes, hypertension, stage 4 CKD, and she presents with elevated potassium with a normal blood pressure. Of note, her potassium is 5.2 and her current eGFR of 21. The blood pressure is noted here at 128/78, and her current meds include lisinopril 40, amlodipine 10, metoprolol XL 12.5 daily. This leads us to our clinical question. PCP Dr. LeBron James would like your recommendation on the indefinite discontinuation of Granny's ACE inhibitor therapy. And the first question that we have for this presentation is, what is the most appropriate treatment plan regarding Granny's ACE inhibitor therapy? And feel free to write your answer on the chat. Is it A, should we discontinue the lisinopril as it has no benefits in advanced CKD? B, should be discontinued to increase Granny's residual renal function. C, lisinopril should be continued as it has benefits in advanced CKD, and we should consider initiating a potassium binder. Or D, we should get the Tune Squad together to learn more about the RAAS blockade in advanced CKD. I'll give you guys a few seconds. I see a couple of answers in the chat. So yes, I do have to agree. So it's early in the game, and Bugs Bunny said, "What's up, Doc? First, let's get the Tune Squad together to learn more about the RAAS blockade, and then we'll come back to this patient case at the end." So at this time, I would like to come to our setting. So RAAS blockade is old school, similar to Looney Tunes. In any type of setting, I'm sure you guys have seen ACE inhibitors or ARBs being discontinued due to the risk of adverse events. But have you ever considered what are the long-term consequences that might arise due to therapy being discontinued and never restarted? And that's why one of the reasons I chose this topic to kind of discuss and reduce gaps in the continuum of care for patients with CKD. First, I'd like to kind of orient you with some background information. CKD affects more than 37 million Americans, which is 1 in 7 US adults. Prevalence of advanced CKD ranges from 20 to 30% and is more prevalent in older individuals, females, and racial minorities. Diabetes and hypertension are the most common causes of CKD and end-stage kidney disease, with diabetes accounting for about 44% of new cases. And currently, 2 in 1,000 Americans are living with end-stage kidney disease. It's important to know not everyone will progress to end-stage kidney disease, but if we detect CKD early, we can definitely use treatment to slow down the progression and delay kidney failure. Next, I would like to kind of talk about the KDIGO stages of CKD, which is included in this table. There are 5 stages of CKD. According to the KDIGO guidelines, CKD is classified based on the cause as well as current GFR and albuminuria category. The colors on the right illustrate the risk of progression to end-stage kidney disease, with green being no presence of CKD, and red at the bottom meaning there's very high risk of progression to end-stage kidney disease. More so, the numbers listed on the right illustrate the number of times these patients should be seen per year, including how many times we should be monitoring their labs, including eGFRs, the renal function panel, as well as albumin-creatinine ratios. And for the purpose of this presentation, I'll be focusing specifically on advanced CKD patients, which includes patients in stage 4 and stage 5, or have eGFRs of less than 30. And once again, for these patients should be seen at least every 3 months in clinic. Next, I would like to kind of orient you to what is CKD. CKD is defined as abnormalities of kidney structure or function that would impede the patient's health. From this, we will look for markers of kidney damage, which include albuminuria or electrolyte or other abnormalities due to tubular disorders, and of course, having a decreased GFR of less than 60. And this has to be present for at least 3 months. Next, I would like to kind of go back to our pathophysiology and kind of go back to our first years of school. So as mentioned before, diabetes and hypertension are the leading causes of CKD. Progression of CKD is due to activation of metabolic, humoral, and hemodynamic dysfunction. And for the purpose of this presentation, we'll mostly focus on hemodynamic dysfunction and humoral activation that results in CKD progression. So starting from the left, RAAS activation induces vasoconstriction and sodium chloride reabsorption, and this leads to fluid retention, ultimately causing left ventricular hypertrophy, as well as aldosterone synthesis and ultimately oxidative stress. Chronic increases in the intraglomerular pressure leads to glomerular hyperfiltration, which then kicks renal injury, causing proteinuria, as well as renal fibrosis. On the other hand, when you activate mineralocorticoid receptors, This causes inflammation as well as fibrosis, leading to progressive kidney disease, as well as cardiovascular dysfunction. This equality of factors, if left unregulated, can lead to further negative outcomes, including cardiovascular and renal, which includes MACE or progression to end-stage kidney disease. So what can we do? RAAS blockade has renal protective properties that we know based on literature, and particularly due to its hemodynamic and non-hemodynamic effects, primarily assisting by decreasing efferent arterial pressure, inhibiting aldosterone synthesis, as well as reducing proteinuria and inhibiting renal fibrosis, mostly due to reducing cytokine production such as TGF-beta. And finally, these agents can be used to decrease MACE by assisting with blood pressure control. And as a quick reminder, we'll quickly review the RAAS cascade. As we learned, RAAS has a key role in regulating the cardiovascular system as well as renal homeostasis. Medications that block RAAS blockade are the cornerstone for treatment to prevent CKD for many decades. First, we have renin, which is released primarily by the kidneys and stimulates the formation of angiotensin-1 in the blood and tissues. And this is done by the addition of the angiotensinogen enzyme. This further goes into angiotensin-1, which is further converted to angiotensin-2 by the angiotensin converting enzyme that is produced in the lungs. And ultimately, angiotensin-2 has several important factors such that include activation of the adrenal cortex to release aldosterone. And ultimately, therapy manipulation of this pathway is very important in treating hypertension, heart failure, and CKD. Such therapies include ACE inhibitors, ARBs, mineral receptor antagonist, as well as direct renin inhibitors. And for this presentation, I'll be mostly focusing on ACE inhibitors and ARBs. As a quick review, progression of CKD is linked to several complications that contribute to high morbidity and poor quality of life. Some of these complications are listed here, which include hypertension, anemia, volume overload, metabolic acidosis, and abnormalities. And for this slide, I would like to point at the bottom that RAAS inhibition or RAAS blockade, as well as newer agents such as SGLT2 inhibitors and finerenone, which are non-steroidal mineral receptor antagonists, are being used to reduce albuminuria and slow CKD progression. So now let's take a deeper look into these agents, since we know that we're going to initiate for patients who have CKD. ACE inhibitors and ARBs can lead to hyperkalemia, hypotension, early decrease in GFR, cause angioedema. And we should monitor electrolytes and blood pressure as well as renal function for both safety and efficacy. These agents should not be used for patients who are pregnant, who develop a cough with use of blockade, have a history of angioedema, or bilateral renal artery stenosis. So this brings us to our first knowledge check. Which of the following statements regarding the manifestation of CKD is accurate? Feel free to include your response in the chat. Is it A, respiratory acidosis occurs frequently in patients with CKD? Hypokalemia is common in patients with CKD. Anemia is a complication of CKD, or D, fluid and electrolyte disorders are not common in patients with CKD. Good job, everyone. Correct, the answer is C. And we'll move forward. I quickly want to talk about evidence favoring RAAS blockade and to kind of learn more about its place in therapy. So quickly, we'll review some literature. So looking at our first study, Brenner and colleagues found that losartan conferred significant renal benefits in patients who were diabetic without hypertension. Second, Lewis and colleagues found that ibuprofen was superior to amlodipine and placebo at protecting the progression of type 2 nephropathy, as well as decreasing death and MACE. Our third study by Agudo and colleagues found that in 1,000 African-American patients with hypertensive renal disease, Ramipril actually, compared to amlodipine, reduced the renal disease progression in patients with or without proteinuria. And fourthly, Hugh and colleagues demonstrated that initiation of ACE inhibitors had substantial renal benefits in patients without diabetes who had advanced renal insufficiency. And lastly, Hugh and colleagues found that RAAS blockade initiation, specifically in advanced CKD patients, reduced the risk of kidney replacement therapy, but found no difference in cardiovascular protection. Over the past 20 years, numerous studies have demonstrated that inhibition of RAAS blockade is extremely effective in slowing progression of clinical CKD, but there are limited studies out there that include or show evidence for patients who have advanced CKD. Currently, the KDIGO guidelines in terms of when agents should be used, they recommend that RAAS blockades such as ACE inhibitors or ARBs be used in hypertensive adults with CKD plus moderate to severe albuminuria, which includes, as a reminder, having urine protein excretion greater than 30 milligrams per deciliter. And secondly, patients who are diabetic and have albuminuria plus or minus hypertension should also be using RAAS blockade therapies. These guidelines give recommendations on who should be on it, but as well as how should they be managed. Providers should be using the highest approved dose if the patient is able to tolerate it, as well as lowering the dose if patients have eGFRs of less than 45. And we should temporarily hold it if the patient has a concurrent illness or has planned IV contrast administration or will be having a procedure soon. But the most recent 2021 guidelines have no recommendations onto when therapy should be discontinued or terminated. With medications, we should always discuss risk versus benefits with our patients, and so far mentioned all the great benefits of RAAS. Benefits being decreased mortality, decrease in MACE, as well as delaying CKD progression, but it's important to note the risks that come with such therapies. Some risks involve RAAS blockade, increasing the risk for hyperkalemia, and just being on ACE inhibitors or ARBs can actually increase the odds of hyperkalemia by 22 to 57%. And hyperkalemia actually is 3 times more prevalent in patients who have advanced CKD versus earlier stages. More so during times of reduced renal perfusion, which occurred during hypovolemia or renal artery stenosis, this drug can promote ACEi development. And finally, a rising serum creatinine usually begins a few days after therapy is started, but this is noted as permissive hyperkalemia, and patients should be monitored. And in late stages of CKD, some providers are hesitant as to therapy should be continued or should be held due to the increased risk of adverse events. This leads me to our second knowledge check, or our second checkpoint. So now it's time for a team huddle, and the question is, based on literature presented earlier, RAAS blockade has demonstrated benefit in which disease state? Is it A, angioedema? Is it B, Stevens-Johnson syndrome? C, renal artery stenosis? Or D, diabetic nephropathy? Feel free to put your answer in the chat. I'll give you guys a couple of seconds. Yes, correct, everyone. The correct answer is D, I agree. So RAAS blockade has demonstrated effectiveness in decreasing proteinuria, as well as delaying CKD progression in patients with diabetic nephropathy. So now leading to kind of the controversy and like, why are we talking about this currently? So as a reminder, individuals who have advanced CKD are those that have eGFRs of less than 30 and are on the edge of progressing to end-stage kidney disease. So as clinicians, we always ask ourselves, so what can we do to buy more time or delay the initiation of renal replacement therapy? Currently, there is a long-standing dogma that continuing RAAS blockade can actually worsen renal function, specifically for patients who have advanced CKD and cause late onset renal failure. And actually in 2016, the National Kidney Foundation conducted a survey with over 1,000 nephrologists and found that 46% of providers were more likely to discontinue RAS blockade once patients' eGFR had decreased to less than 20. But I do want to review this quick study from 2008 that brought lots of controversy. So this observational study enrolled 100 Caucasian CKD patients who were on RAS blockade and had a mean eGFR of 22. These patients did have worsening acythemia with a 25% increase in baseline serum creatinine. And the objective of the study was to evaluate renal function after RAS blockade discontinuation. Others noted that majority of these patients in the study actually had significant and sustained eGFRs following discontinuation of RAS blockade, with the mean follow-up of 26 months. And others only noted that only 16 patients out of the 100 actually progressed to kidney replacement therapy. So this study was kind of the first to kind of build a hypothesis of, does RAS blockade lead to improved GFRs? And this is where the next study comes along with Ahmed and colleagues. So they kind of wanted to make more, have a bigger patient population. From that, they looked specifically at advanced CKD patients, but they were only able to enroll 52 patients. And from that, these patients of note were followed by nephrologists, and they were anticipating kidney replacement therapy in the next upcoming months. The average eGFR was of 16, and then authors did note that after 12 months, once therapy was discontinued, these patients did have an increase in their eGFRs, increasing from a mean of 16 to 27, and the decline in eGFR was actually reversed after 12 months. And authors noted that discontinuation of ACE inhibitors and ARBs undoubtedly delayed the onset of kidney replacement therapy in majority of those studied. And of course, these are only observational studies, and that should be taken with a grain of salt, since they can produce recall bias and are a major threat in terms of internal validity and credibility of other studies that use self-reported data. So this leads to my clinical question. Is it safe and effective to discontinue ACE inhibitors and ARB therapy in patients with advanced CKD? With that, we'll take some time to get the Toon Squad back together to help us answer this question. So to introduce our team, we have standing at 3 feet and 3 inches, and then 4 feet if you include his ears, is Bugs Bunny, which will represent Chiao and colleagues. Standing at 5 feet in height, we'll have Sylvester the cat represent Fu and colleagues. And finally, the best player in Looney Tune Land, standing at 3 feet and 2 inches in height, we'll have Lola and Bunny represent our most recent study, Bandari and colleagues. So first we'll get into the first study. This was published in 2020 by Chiao and colleagues, and it was the first study to kind of review the association between discontinuation of ACE inhibitors or ARB therapies after eGFR decreased to below 30. Of note, this was a retrospective propensity score match cohort study, and the primary outcome was primarily at safety and mortality at 5 years from baseline. And baseline was defined as a window of 6 months after the eGFR had decreased to less than 30. Patients were included if they were over 18, had received therapy for at least 6 months, and were excluded if they had stopped therapy before the eGFR had decreased to less than 30, or if therapy was restarted or discontinued within a 6-month index period. It's important to note that patients who were included had a baseline characteristic, those specifically who had discontinued were included, had about 1,200 patients, compared to the control group. And of those who continued therapy, they had over 2,600 patients. In this study, the mean age was of 73 years, mostly white females, with a mean eGFR of in the lower 20s, placing them once again at stage 4 CKD. Of note, these patients were well controlled in terms of hypertension and kalemia. Investigators found after the propensity score match sample of over 2,400 patients that therapy discontinuation at almost 3 years was associated with a higher risk of mortality and MACE. I've included here the hazard ratios, but there is no significant difference in the risk of end-stage kidney disease. When looking at safety parameters, as suspected, those who discontinued therapy had lower portion of hyperkalemia compared to those who continued therapy at 16 versus 22%. And finally, the risk of ACEi was also did not significantly differ between both groups. When assessing or critiquing this study, it's important to note that this study was the biggest at its current published state, but looking at its design, its method did minimize any confounding variables in terms of their scoring. As well, it also included subcohort analyses of different eGFRs and found no differences at eGFRs of less than 30 or less than 15. And after the limitations, once again, this is an observational study, and it's also retrospective, which is validity. It also, like patient diversity, which can affect externality, specifically for our patient population here at University Health. And of note, this study did exclude high-risk patients that we would definitely want to know what are the effects of stopping therapy. So those who have hypertension, ACEi, or hyperkalemia at baseline. Key takeaways for the study is that findings suggest that continuing ACE inhibitors or ARB therapies in patients with declining kidney function may be associated with a cardiovascular benefit, no statistical significance in terms of end-stage kidney disease. We'll now switch gears to our second study, once again presented by Sylvester Blockade, which was published in 2021 by Wuen colleagues. And the objective of the study was to evaluate the long-term outcomes of patients who were on RAAS inhibitors, who had stopped or continued therapy after developing advanced CKD. Similar to our first study, this study was looking more for safety and all-cause mortality at 5 years for its primary outcome. Patients were included if they experienced CKD stage 4 through 5 and were adherent to their medication, which was defined as precision ratios greater than 80%, and were excluded if they had stopped therapy before they decreased its GFR to less than 30, or had a history of kidney transplantation, or had any missing vitals at the index date. After cloning, the study, this included over 10,000 patients who were assigned to each treatment strategy. And for this study specifically, the mean age was of 72 years and primarily had males whose primary cause of CKD was diabetes, followed by hypertension, which is what we typically see in the normal population. Patients had a mean eGFR of 23, and the mean urinary albumin-creatinine ratio was of 35, which equates to about 310, being classified as A3, or having presence of macroalbuminuria. Authors did note, in terms of the results, that discontinuing RAAS blockade was actually associated with an increase in its 5-year absolute risk of mortality, as well as MACE, with 13.6 and 11.9% respectively. But there was an 8.3% in absolute risk of initiating kidney replacement therapy. And now for the critique. So this being, I guess, the second largest observational study to date, one of the biggest things was these patients were followed by nephrology or kidney experts, and it did have a longer follow-up period compared to our first study. In terms of limitations, of course, this is retrospective, which is limited to internal validity once again, and it did lack information regarding race and safety. And then this study was actually conducted in the UK, which also is not easily generalizable to our US population here. And key takeaways for this study is that stopping RAAS inhibitor blockade among patients who have referred to nephrologists with advanced CKD It was associated with an increased absolute risk of mortality and MACE, and there was a lower absolute risk for kidney replacement therapy. And now looking at our final study represented by Lola and Bunny, this was actually an open label randomized control trial published in 2022. Its acronym actually is STOP-ACE. And the objective was to evaluate whether discontinuation of RAAS blockade would increase or stabilize eGFR in patients with advanced and progressive CKD. And this is the only study that actually to date that assesses efficacy or renal function once therapy is discontinued or continued once eGFR falls below less than 30. Patients were included if they RAAS blockade therapy on board for at least 6 months and had stage 4 or 5 CKD with progressive deterioration, which was defined as having a decrease in eGFR greater than 2 per year in the previous 2 years. They were excluded if they were on dialysis or had uncontrolled hypertension or had a history of MI or stroke. And looking at baseline characteristics, the study screened over 1,700 patients at 39 centers. And of those patients, only 411 patients were actually went randomization groups. The study was also conducted in the UK, which primarily included white males over the age of 65 and had severely increased albuminuria. And the mean eGFR was less than 20, placing them at stage 4 CKD. Of note, only 28% of patients had stage 5 CKD. And it's also important to note, compared to our second study and just general population, the main cause for CKD for these patients was glomerulonephritis, followed by diabetic nephropathy. And looking at the results of the study, once again, this is the first study to date that's currently published that assessed changes in eGFR once therapy discontinued. So at 3 years, investigators found that patients in the discontinuation group did not have a clinically relevant increase in eGFR. And then authors also found that the number of patients who underwent end-stage kidney disease or kidney replacement therapy was very similar in both groups, those who had discontinued or remained on therapy, similar to cardiovascular events and deaths. And there was no differences in terms of blood pressure and albuminuria. And looking at safety in terms of CV events, there was a numerically higher number of CV events in patients who had discontinued therapy. However, there was less patients who experienced hyperkalemia, and there was no differences in terms of ACEi and hypertension. But it's important to note that this is only safety parameters, and the study was not powered enough to investigate its effects in terms of cardiovascular and mortality. In terms of critiques, it is the first randomized control trial of its kind, and it was conducted in multiple centers, which provides generalized results. However, it was a small sample size of about 410 patients. And as mentioned before, it was underpowered to detect MACE or CV mortality. Since it was conducted in the UK, it also underrepresented non-white racial and ethnic groups. And lastly, being that it was an open label trial, this can affect internal validity. And looking at the key takeaways for this study, so findings do not support the hypothesis that the discontinuation of RAAS blockade in patients with advanced and progressive CKD would improve kidney function. And this study was once again underpowered to detect differences in terms of end-stage kidney disease and CV impact. And I know that was a lot. So once again, as a reminder, we'll quickly review the results for all 3 studies. And the clinical question once again was, is it safe and effective to discontinue ACE inhibitor and ARB therapy in patients with advanced CKD? And once again, we'll get the group together to help us answer this question. And as a summary, Xiao and colleagues in 2020 found that cessation of RAAS blockade in advanced CKD was associated with an increased number of deaths and CV events, versus Wuen colleagues in 2021 found that cessation of RAAS blockade in advanced CKD was also associated with an increased number of deaths and CV events, but lowered the risk of kidney replacement therapy. And lastly, Bandari and colleagues in 2022 found that cessation in therapy was not associated with improvement in kidney function. So bottom line, RAAS blockade should be continued in this patient population due to its increased risk for death and CV events when discontinued. And really, there's no way of us saying that, okay, well, once we stop therapy, renal function will improve. And with this, I included some clinical recommendations to kind of assist us with guiding our patients to like, what can we do if we're faced with this dilemma? So starting from the top, so patients who are in stage 4 or 5, and they're currently on ACE inhibitors or ARB, we should do patient-specific considerations. So starting from the left, if a patient comes in on therapy and they are having hypertension, we should consider doing a dose reduction and reassessing what we should do in about 2 to 3 weeks. And then going to the right, if we see that these patients aren't able to have close follow-up, there's lack of transportation, they have a no-show rate, then this favors discontinuation, as these agents do have, once again, a higher risk for adverse events. And going towards the middle, once we see these patients, very important for us to eliminate any concurrent nephrotoxic agents, such as NSAIDs, other agents, and then limit dietary potassium intake and have close follow-up every 4 to 12 weeks. And once again, based on the KDIGO guidelines, these patients should be followed at least every 3 months. And with that, we should assess potassium and renal function. And going from potassium greater than 5, if they do present with hyperkalemia, then we should consider initiating potassium binders for about a week or so, and then we assess after 1 to 2 weeks. And if there's persistent hyperkalemia, then we should consider doing a dose reduction or hold therapy temporarily. And then if the patient does have an AKI and has unstable renal function, then we should hold therapy temporarily and assess therapy in 2 to 3 weeks. And once these patients are normocalemic and have stable renal function, then we should definitely get these agents back on board or continue these agents in general. With that, we'll go back to our patient case that was presented earlier. So Granny's a 72-year-old female who presents her PCP for a sports physical. She has a past medical history of type 2 diabetes, hypertension, and stage 4 CKD, and she has elevated potassium and a normal blood pressure in clinic. Her current regimen includes lisinopril 40 milligrams on Lonapine 10 and metoprolol 12.5. Of note, her potassium is 5.2 and eGFR of 21. So once again, our question is, PCP Dr. LeBron James, like your recommendation on indefinitely discontinuing Granny's ACE inhibitor therapy. What is the most appropriate treatment plan regarding her therapy? And feel free to provide your answer on the chat. Is it A, lisinopril should be discontinued as it has no benefits in advanced CKD? Lisinopril should be discontinued to increase Granny's residual renal function. C, lisinopril should be continued as it has benefits in advanced CKD patients, and we should consider initiating a potassium binder. Or D, let's get the team squad back together and do a second round. Give you guys a couple more seconds. Yes, I agree, guys. Great job, slam dunk. So C, once again, bottom line, these patients should be continued on RAAS blockade to increase risk for death and CV events. With that, I want to give some acknowledgements to my mentors as well as my leadership. And then I do have more questions to kind of help us drive this home. So they'll be real quick, and then feel free to answer the questions on the chat. Question 1 is, which of the following factors indicates an increased risk of advancement to higher stages of kidney disease? Is it A, an increase in GFR, B, hypertension, C, proteinuria, or D, loss of protein? Great job, everyone. Yes, the correct answer is C. Going to question number 2, which of the following patient is a candidate for RAAS blockade? Is it A, a 34-year-old pregnant female with newly diagnosed hypertension, B, a 45-year-old male with diabetes plus albuminuria, or C, a 60-year-old female with hypertension plus stage 4 CKD, or D, both B and C? Correct, guys. The correct answer is D. Going to question number 3.
Quick question on question 2.
Yeah.
Is there any like end stage or certain levels to not initiate a RAAS inhibitor besides like the other contraindications?
I think with that, definitely like look at the patient as a whole. Of course, you can have the renal functioning to see, I guess, as been stable. But with that, I mean, if the patient, let's say with stage 4, stage 5, they're starting even slow, like a low dose, less than 2.5, and seeing how they tolerate that. And then once they're able to kind of increase to the 5, then you can do that then. But current guidelines don't give any recommendations as like, okay, well, once they have a threshold of less than 30, then don't start it.
Okay, cool, thanks.
No problem. Thank you for the question. So going to question 3, LJ is a 38-year-old male with diabetes, hypertension, and CKD. Due to LJ's poorly controlled diabetes and hypertension, he has now progressed to advanced CKD. He is currently being treated on empagliflozin 25 milligrams, valsartan 100 daily, amlodipine 5 milligrams. Based on available literature that was presented earlier, which of the following is a potential benefit in continuing RAAS blockade in patients with advanced CKD? Is it A, weight loss, D, resolution of infection, C, decrease in CV death, or D, normal glycemia? All right, guys, the correct answer is C, decrease CV death. And then my last question is a patient case. So MJ is a 69-year-old male who presents his annual visit. Past medical history includes hypertension, stage 4 CKD, and diabetes. And he's currently being treated on empagliflozin 10 milligrams, lisinopril 40 milligrams daily, and metoprolol 25. Today, he is euvolemic and hypertensive in clinic. Of note, he recently increased lisinopril from 20 to 40 milligrams, and his repeat labs show elevated potassium with a small increase in serum creatinine. Your colleague is requesting a recommendation regarding his RAAS blockade. So once again, his potassium went from 4.3 to 5.4 after you increase lisinopril from 20 to 40 milligrams. So the question is, what recommendation would you present to the team? Is it A, there's no change to his regimen as his blood pressure is controlled? D, we should replace lisinopril with verapamil. C, we should stop lisinopril as it has no place in therapy. Or D, we should continue lisinopril, we should reduce its dose back to 20 milligrams. Correct, guys, yes. The correct answer is D. Definitely making efforts to continue therapy and then reducing the dose as he was previously stable on the 20 milligrams and assessing for other risk factors or causes of an increase in creatinine. So with that, that's all, folks, in terms of my presentation. And now I'm open to any questions, and these are my references.
I have a question about the potassium binders because I think it was last year, and I'm not sure if it's still the same, that whenever we tried to start the potassium binder, we got a call from pharmacy that we required approval from nephrology before placing the prescription, and given that we will probably need to prescribe that if we want to keep the ACE and ARB, do you know what will be the fastest way to have that approval, or that approval is not necessarily needed with that patient, with all the patients?
That's a really good question. As being that I'm pharmacy, I should know the answer to that. Let me do a quick search. But I do remember that there is a restriction to nephrology, but I do believe there's also like one of the qualifications saying that if you do less than 7 days, then it should be okay for you to continue. But I'll confirm that for you real quick.
Thank you.
And then one of the benefits too of, I guess, our preferred potassium binder here in clinic, I guess, if you do have a patient who will be low-calma, specifically because most of our patients are uninjured, and there is a MAP or assistance program for that drug. I'm looking at the, I guess, the current restriction or criteria, and you're right. It does say it's restricted to nephrology for initiation, and then primary care providers should continue therapy that was initiated by nephrology, but that has no recommendation as to like, okay, well, what happens if we need a short course, or what should we do? But let me get back to you on that. I can talk to Dr. Buzzle and see what I guess the recommendation is.
Thank you, thank you. I think the time when I saw that we were able to prescribe it, she called, I think she called the backline from another pharmacist from nephrology, but I'm not sure if we as regular providers are allowed to make that phone call, but that's the way she did it the last time.
I'll check in with her and I'll let you know. I don't want to give you the wrong info. Of note, it's also covered if you started inpatient, then you're able to continue it as at discharge. And they do cover that, or they do allow it to can be continued outpatient.
All right, any more questions or comments for Dr. Hernandez? No. All right, well, thank you, Dr. Hernandez, for your presentation, and thank you everyone for joining, and have a good rest of your afternoon.
Thank you for having me. Bye, everyone.